It's a controversy. I think you like it very much. And every year we try to find answers to difficult questions. So we have a session with Adrian and myself, Robert, who is here. We have also on the panel Sonia Salinger, Luc Maillard, Simon Redwood, who is still in England, Alessio Mattesini, and Peter Kayaert. And the first question is simple crossover alone versus side branch opening during one stent strategy. So the first lecture is by Dr. Chang-Wook Nam.
Dear Chairman, thank you for the invitation to present at EBC 2021 meeting. The title of my presentation is No Side Branch Strut Opening After One Stent Simple Crossover Strategy. In the current expert consensus, including EBC, provisional strategy is a standard approach for bifurcation PCI. However, after simple crossover stenting, there are various options for the treatment of side branch ostium. According to the previous FFR study, it is well known that the anatomy and functional discrepancy exists in jailed side branch in non-left main bifurcation. Previous randomized or large registry study demonstrated that the routine side branch opening after simple crossover stenting did not make better clinical outcome up to 5 years. And the incidence of side branch related TLR rate was not different. We know that the benefit of PCI is related to the burden of a target myocardium. And the previous CT study about myocardial mass analysis showed the burden of a side branch myocardium is usually lesser than 10%. However, if side branch myocardial burden is large enough like circumflex, this change may affect clinical outcome. Therefore, we performed several studies about this issue. First, we confirmed that the anatomy and functional discrepancy still exist in jailed circumflex, but still there were concerns about the efficacy and safety of this FFR approach for left main bifurcation. Especially, previous pathologic studies showed the risk of thrombosis in the protein strut of side branch ostium. So our group did a 5-year clinical follow-up after FFR measurement in jailed circumflex. If FFR was low in jailed circumflex, their clinical outcome was very poor. And in those patients, should be treated with additional complex procedure. However, if FFR was negative, more than 8.0, their outcome was acceptable up to 5 years. In terms of a protein strut issue, these endoscopic images from Japanese doctor gave us very important insight. Most of these protein strut are not much thermogenic and were covered with healthy neointima in current biocompatible or biodegradable polymer DES. Furthermore, serial OCT study demonstrated that the minimal lumen area of jailed side branch ostium was well maintained up to 2 years. The most of a protein strut was covered after 1 year. In terms of clinical outcome, 2 large registry data from Korea and Italy showed the strut opening after simple crossover stenting also did not make a better clinical outcome. However, during this provisional strategy, we have to remember the role of pod proximal optimization. COVIS-2 registry data reported that pod make a better outcome during the provisional strategy. And the benefit of pod was observed in the enlarged minimal stent area in proximal part of main vessel, like in this IBS study. And FFR of side branch did not improve after pod technique. Therefore, the positive clinical outcome of pod was originated from the main vessel benefit, not side branch related. So, ladies and gentlemen, this is my summary slide. Previously, we routinely treated side branch strut after simple crossroad stenting with complex procedures. However, according to our experience, when we do the provisional approach, simple crossover stenting with pot, then if it seems to be need additional procedure, just to do FFR. And if FFR is positive, do the additional complex procedure. However, if FFR is negative, medical therapy can be acceptable. Thank you very much for your kind attention.
Thank you very much. So now we move to the opponent, Dr. Takayuki Okamura, who said that we should open the strut toward the side branch.
Dear Chairman, thank you for the invitation to present at the EBC 2001 meeting. The title of my presentation is Side Branch Strut Opening May be Better Approach During One Stent Strategy. Purposes of side branch opening are following. However, the COVID-3 study did not show clinical benefit of side branch treatment. The latest consensus document introduced the fenestrated restenosis at CX ostium 3 years after crossover stenting. In this patient, everolimus eluting stent was implanted crossing over CX without dilatation of the CX ostium. She suffered from acute heart failure 5 years later. At that time, CX was totally occluded. When intervention was performed to the gelled CX, balloons were ruptured. So we performed rotablator followed by dilatation with scoring balloon and DCB. 1 year later, ostial restenosis was found again. We performed T-stent. But next year, CX was occluded. Then he underwent bypass surgery. When we declined to open the side branch during initial procedure, we occasionally need complicated and difficult procedures later. The serial OCT observation of the jailed side branch without opening revealed that side branch ostium area decreased according to the jailing complexity. Small compartments divided by struts were filled with tissue attachment. However, kissing balloon may have potential problems. Meta-analysis showed KBI decreased risk of side branch restenosis, while an increased risk of main vessel restenosis. POT can induce a constant increase in cell size area of side branch ostium. In the E-Archmaster bifurcation subgroup analysis, POT reduced consistently clinical events compared to no POT, while final kissing balloon did not show significant reduction of the events. Either use of POT or KBT reduced the clinical event. POT plus KBT showed the best clinical outcome, while the simple keep it open strategy showed the worst clinical outcome. This analysis suggests that POT should be done regardless side branch treatment. Improvement of kissing balloon technique has been reported. The short overlapping KBT has been introduced. The RAIN study showed the reduction of the TLR in the short overlapping KBT group. When side branch is open, the distal recrossing is recommended. In the optimal trial, however, the frequency of the distal recrossing identified by the first 3D OFDI was 55%. This suggests that 40% of side branch dilatation may not be performed optimally. Handled achievement of the distal rewiring under online 3D OFDI guidance reduced acute ether at bifurcation segment compared to the angiographic guidance. Our registry shows that frequency of angiographic side branch restenosis in the optimal side branch dilatation, which achieved both distal rewiring and no stent link at carina, tend to be smaller than that in the other condition. If strut configuration is unfavorable for side branch dilatation, POT alone may be better choice than side branch opening without optimal condition. Decision making according to the 3D OCT findings may improve clinical outcome. After study period of COVID-3, new insights from imaging study and technical improvement of side branch treatment were introduced. The new techniques may improve clinical outcome. I'd like to summarize my presentation. I believe that side branch strut opening during single stent strategy should be performed because we may encounter the gelled side branch stenosis sometimes at very remote phase after single crossover stenting without side branch opening. Gelling struts with severe neo-inchmal proliferation at side branch ostium could make it difficult to perform PCI. Contemporary best practice for side branch strut opening could improve clinical outcome. Thank you very much for your kind attention.
Thank you very much, Dr. Nakamura. So these two lectures are open for discussion, and I suggest that at the end we'll have a vote. So the question is, should we open the strut toward the side branch in the majority of cases, or should we just leave it like that, maybe with a pot at the end? So, Adrian, you are, I don't see you. Yes, you are here.
Thanks, Thierry. I mean, I think one of the additional questions here is really perhaps to separate the left main from other bifurcations. And, you know, I can certainly understand why in an OM you might choose not to do a kissing if the OM branch itself is not large. But for a decent-sized circumflex, you know, that's, I think, really where the debate is, isn't it? And perhaps we should focus really on the left main with regard to the discussion, because I think that will probably bring out slightly more strong views.
Yeah, I fully agree. And we are talking, of course, about big side branches, and the left main is a very good example. So let's focus on left main, if you agree.
Yeah, I think that sounds great. So perhaps we should ask Vlad. Vlad's always got a good view. So what do you think, Vlad?
Yeah, I think it depends on the anatomy. I mean, there are, the most important thing to me is to maintain the integrity of the main vessel stent, even if that's left main into LAD. And I've seen situations where by kissing, where you actually distort the left main. So I think this all has to be image guided. There are situations with large circumflex with normal lumina where I don't know that it's essential, and I think we need better studies for this, but I don't know if it's essential to always recross and always do a kiss in the circumflex, the left main bifurcation. That's my, in others it is. So I think it depends on the individual situation for me.
I mean, the issue often with assessing the side branch, one of the things I enjoyed about Dr. Wook Nam's presentation was the idea that using physiology can then decide whether you want to image, because that's the problem often, isn't it? If you want to image the side branch, you're almost obliged really to start opening struts in order to get your imaging catheter in. So therefore you're in play. And then, as you say, it has its own momentum probably then as well, because you then sort of feel as if you might be lifting stuff, and it can be difficult, and it kind of takes on its own life to a certain extent. Simon, what's your practice in the left main?
Regardless of whether this is left main, my practice is not to routinely recross into side branches and balloon them. It's always worried me that you'll destroy the stent anatomy of the main vessel stent, and you're also balloon injuring the side branch of the ostium. So I don't do it routinely. I would do it if the FFR was less than 0.8. I think you can almost always get a pressure wire down even without dilating the side branch. I would do it if the flow was less than TIMI3 or the patient had chest pain or ECG changes, but otherwise I would leave it well alone.
Yeah, we have learned from Ronnie Matthew several years ago that when you leave the strut unopened in the circ, there is a colonization with the endothelial cells, like we have seen with BVS, and Patrick has shown bridge of neo-endothelization who stay forever. And he showed several cases of subocclusion, even occlusions of the side branch due to these neo-endothelial cells, which are not restenosis. It's just colonization of the strut by the neo-endothelial cell that you can open, do a kiss, and restore without adding a stent. So I think this is a relatively good argument. Of course, you don't see that every day, but I think it's a good argument. And the other one is when the patient has a lesion in the marginal that you have to treat, you have to open 4 years, 5 years, 10 years later, the strut, and sometimes it's very difficult. And we have seen in the previous presentation that they have to use rotablator in some cases. So we have to face some difficulties when we have not opened the strut toward the big side branch, in my opinion. So maybe we can ask to the panel what does they think.
Yeah, Thierry, I think it's wise to try to structure the discussion. I think it's very good. We have seen the data and we have heard the experts. For the moment, I think that if we try to get some consensus, we should try to fix as much focus on the data available. And that seems to be that we don't have demonstrated benefits. And then we try to have to understand in which patients we do see these problems. So potentially it helps us to have the FFR to demonstrate which patients potentially benefit. And I also think that our studies have failed. We have learned that from the Japanese, that if we do fenestration and a kiss, if we don't do it optimal, we even make it worse. So potentially I think that if we want to do a comparative study, we have to first optimize the kissing by using the good cells, because making it worse is not what we want to do to our patients. So in this moment, I think we cannot recommend to open it because we don't have the data. And we have some patients who have a problem in the long term, which seems to be adding on the long term. But to treating them all to prevent some events in the future, I'm not sure if that's the best strategy. And I would like to add one comment to my personal experience in here is that if you wait a few months, then it gets easier because, from all the opening areas we have, all the small ones are disappeared by Neo-Intima. So you only have 1 or 2 larger ones, which are usually the more distal ones than the very proximal one, which is the small one you want to avoid. So for me personally, doing a second procedure is not always the most complex procedure. In the initial procedure, you have much more areas that you underneath some struts, in between some struts, a small cell trying to open up to the side branch. In 3 months, usually some of the small areas are covered, and it makes it easier for me.
So you were talking about data, but it's only a personal opinion.
Okay, so
so Luc, you will have maybe personal opinion too.
No, a short comment. I will say, because we don't have a lot of data, it will depend of routine practice. Okay, how big is the side branch? How big is the balloon you are going to put inside to optimize the result? And how important is the quantity of myocardium concerned by the side branch bifurcation? So I will differ and make a big difference between left main, except for very small circumflex, and the other bifurcation. And recently I observed bias, especially with the new stent with very small thin struts. It changed, honestly, the way to approach a small bifurcation for third diagonal, second marginal, because you can fulfill it. And that's a little point. So that's interesting.
Yes,
yeah,
go ahead.
Maybe for me, I think the argument you gave, Thierry, is very important. Is that if the side branch shows a lot of disease and the probabilities for future events and treatments there, I think that's an argument to go further than and open the cell. And in the non-left main lesions, I think if we go for other things than just POT, I think we have to be really sure that we really did a good kissing and a distal cell opening, because sometimes we think we did it well and actually we are compromising the main branch. So I think there is more and more an indication for imaging in also if we go for kissing.
Thank you very much. Any opinion in the room? Yes, Marek. And then we will have to vote. Of course, it's a controversy, so the opinions are different.
In general, we have enough data from OCT and IVUS. In around 66%, we have a mixed plaque distribution. So usually plaques are going from left main to LAD, that makes around 90%, but the mixture of both ways is in around 66%. So I think that's the question. If you just believe one day we need maybe we have to go to the circ, then at least in our center we do always final kissing for distal left main PCI. That's a standard.
Ahmad.
Well, I think the main problem is to leave easy access to the vessel, not opening or not opening the strut. And this can be checked by rewiring the vessel and going with a balloon. If you don't have any friction, if it is easy to access, I think it is enough. That means you have, also in the future, have easy access to the side branch. This is from practical point of view.
But don't you think that if the access is difficult, it's even better to open the strut?
If you have some friction, then or not easy, you are not able to cross with a balloon. I think it is good to check with IVUS and see, or intravascular imaging, and see what is the problem, and to correct that problem.
Okay, so it's time to vote. So the question is, when treating the left main, crossover from left main to LED, should we open the strut or not? So who is in favor of not opening the strut?
So perhaps a comment, Thierry. One of the arguments here is that what we're trying to do is to look toward statements that would be included in our next consensus document. One of the things I was hearing there is, if you're going to consider kissing, then imaging is highly recommended. I mean, that's a sort of sentence that I don't think many people in the room would perhaps argue with, but I don't know how that sits with you.
For me, that's an important, Adrian. I think that to make it that it has to be done always, or so the wording is always very critical. Initial statement on the text for the program is any side branch. Now we have changed it to left main already. And then say, is that only FFR positive side branches, or whatever we want to do?
I can just make a quick comment. I think that we've talked a lot about POT, and I've heard a lot about POT in prior talks as well. And I think that's a critical piece, and a good POT may obviate the need for KISS and may actually optimize access, will optimize access in the majority of situations to the side branch. So a good POT may well obviate the need for a bad KISS.
So I think the vote is not working, so we'll vote like that. So who is in favor of not opening the strut? Oh.
In the left main, Thierry.
In the left main, yes. Even you?
Yeah, I can vote for yes.
And who is in favor of opening the strut? Okay, so it's a vast majority. I am surprised, but so we can repeat for non-left main bifurcation with a side branch larger than 2.25. Larger than 2.25. Open the strut. Open. And not open. Okay, so 60% not open and 40% open. Okay, thank you very much.
A good controversy, Thierry.
Yeah. So now for left main, you have to open the strut toward the side branch. It's a recommendation of EBC. Okay, so next question is all bifurcations fulfilling the definition 2 criteria should be stented with decacrush technique. So pro is Vladimir Dzavik, difficult task, and con is Bernard Chevalier. So Vladimir?
Mr. Chairman, thank you. It's my pleasure to present the position that all bifurcations fulfilling the definition 2 criteria should be stented with the DK crash technique in this year's controversies at EBC 2021. So how were the definition 2 criteria devised? They came from a definition study published a few years ago, in which case a training group and a study group were utilized to define criteria, and these were the criteria that were eventually defined. Major 1 and major 2, depending on whether it's a left main or non-left main bifurcation of diameter stenosis 70% or 90%, depending on which and in both cases, lesion length greater than 10 millimeters, and any 2 of 6 minor criteria. So this defined a high-risk patient who had a worse outcome in that particular study. This informed the design of definition 2, in which case 660 patients with complex bifurcation lesions were randomized to a provisional strategy or a 2-stent strategy, with clinical follow-up being at 12 months, angiographic follow-up at 13 months. Important because that did not confound the clinical outcomes. So if we were to look at some of the highlights, the complex group of patients, as you can see, mean syntax score 24 in both groups, syntax 2, 30. So these are both angiographic and clinically complex patients, in which over a quarter of the patients actually had a clear recommendation based on the syntax score 2 for bypass surgery, a long lesion length of 20 in the side branch, 40 in the main vessel. So very much a complex group of patients. Procedurally, the majority of the patients in the 2-stent group were treated by the DK crush technique, some with culotte, very few with TAP. In the provisional, it was mostly of course, one stent only in the majority of patients, with those who were treated with a second stent in the side branch. TAP and culotte were primarily utilized. In terms of results, a clear benefit demonstrated for the 2-stent procedure, the majority of which, of course, was DK crush. In terms of TLR, target vessel MI, target lesion failure, significant result with much lower event rates in all of these outcomes for the 2-stent procedure. Now, we have other data as well. In DK Crush 5, the patients were analyzed by complexity, in this case by the NAIRS score and the syntax score. However, if we look specifically at the definition complex and definition simple definitions, we see a clear separation here with a significantly lower event rate in terms of target lesion failure in the DK Crush group specifically compared to provisional stenting. But we also see a trend in the definition simple group. So there is, I would think, some evidence that both groups may benefit. In DK Crush 3, compared to another 2-stent procedure, we see MACE rates at 3 years in the complex group with DK Crush 15.1%, all the way up to 51.5% in the culotte group, highly significant difference favoring the DK Crush group in the complex subset. Just briefly, the European Bifurcation Club left main, somewhat different, but a very important study. But clearly these are not definition complex patients with side branch lengths under 10 millimeters in both groups. A wash, similar results in both the stepwise provisional and systematic dual approach. The techniques that were utilized, interestingly, were very few DK crush, mostly culotte in the systematic dual versus the stepwise provisional. DK crush, in spite of the fact that these patients were enrolled between February 2016 and November 2019, long after publication of DK Crush 2, DK Crush 3, 3-year data from DK Crush 3 as well as DK Crush 5. The DK Crush simply was not adopted, I believe, in Europe in any way. Nonetheless, I think we do have to validate the technique in other populations and ensure that other investigators, other operators can do this as well. So we are actually launching a Access 1, which is a Pan-American randomized controlled trial of DK Crush versus provisional stenting strategy in patients with not quite as complex lesions as in the studies previously suggested, somewhat less complex, but still complex lesions, side branch lesion length greater than 5 millimeters, amongst other characteristics. So in conclusion, until proven otherwise, Mr. Chairman, panelists, the DK crush technique is a preferred technique and provides the best results for patients undergoing PCI of complex definition type true coronary bifurcation lesions or less complex true bifurcation lesions until, again, proven otherwise by new data from other studies. Technique is critical. Prepare meticulously and pot. Say this twice because pot is essential after each crush, and really everyone can do this. This is has a number of steps, but is not a complex, difficult procedure. Mr. Chairman, thank you very much.
Thank you very much, Vladimir. So now we'll ask to Bernard Chevalier who explain why he will not do a DK crush.
Mr. Chairman, dear colleague, it's my pleasure to explain why I think that all definition bifurcation should not be treated with DK crush. First, this kind of lesions are very rare. As you can see, the criteria are very strict. For left main, you need to have a side branch lesion length which is more than 10 millimeters, and a stenosis which is tighter than 70%. Or for non-left main, it should be the same, but with a side branch stenosis greater than 90%. And on top of this criteria, you need to have at least 2 of these minor criteria. It's so rare that it took 3 years to 50 high volume center to enroll 653 patients, a mean enrollment rate of 1.5 patients per center per year. And they use for this trial 7 different types of DES. So clearly the primary endpoint, which was TLF at 1 year, considering that angiographic follow-up is theoretically 1 month later, you can see that this benefit is mainly occurring early regarding target cell macular infarction, and we'll try to understand why. The technique was really perfect in the 2-stent group, but really focused on side branch patency, meaning that 88% of patients receive a side branch stent first, with 77% of DK crush. There was 8% of crossover to one stent technique in this group. Crossover rate was much higher in the provisional group at different steps of the intervention. You can see that side branch dilatation and kissing balloon was performed in only 58 to 56% of the patient. And we have also some patients receiving a stent before the main branch stenting or after the main branch stenting. But in total, we have 8% of side branch transient occlusion, 1% of permanent occlusion, 22% of crossover to 2-stent technique, and at least 27% of side branch did not receive any intervention. The second part of the benefit is occurring late, as you can see regarding this bump of TLR in the provisional group at 12 months. Theoretically, the angiographic follow-up should take place after clinical follow-up. But in fact, in 29% of cases, it occurs before 1 year. And you can see also that the delay for angiographic follow-up has a relatively large standard deviation, meaning that some patients have been angiographically controlled before the 12-month clinical follow-up. You can see that the result in terms of MLD post-PCI was, of course, lower than the patient receiving stent. And we are very close with 0.032, which is relatively standard late loss for balloon angioplasty. Stenosis adverse term was 26% at angiographic follow-up at 1 year. But when you see the result post-PCI, you can see that the remaining stenosis, the residual stenosis is 30% plus or minus 21%, meaning that some patients already fulfilled the restenosis criteria at the time of the PCI. When we consider restenosis on TLR, you can see that regarding the main branch, proximal or distal, There is no difference in terms of free stenosis between the two groups. The difference is only related to side branch free stenosis, which is 9 versus 26%, inducing higher TLR, as you can see. So clearly, in case of definition criteria, optimal two-stent technique is superior to suboptimal provisional strategy to maintain side branch patency. Is decay crush better than over two-stent technique? Difficult to say. There are few head-to-head comparisons of two-stent technique using modern DES. There is decay crush free versus culotte, and there is also with culotte versus tap in BBK2. But when you look at the rate of free stenosis at the side branch, it's 12% in decay crush free and only 6% in BBK2. That means, in my opinion, that experience with a two-stent technique is probably more important than the technique itself. The role of appropriate metal coverage, using multiple pots, double kissing, and appropriate cell rewiring, which is, of course, the difference between culotte and decay crush. Can we extrapolate that to all bifurcation? Certainly not. Even in EBC2 and EBC main, there was a failure to show superiority of two-stent technique, and we have to consider that when we look at the long-term outcome, the 5-year all-cause mortality is higher in two-stent versus one-stent. So a two take-home message for me regarding definition. First, adjust the complexity of stenting technique to the complexity of bifurcation lesion. Second, use a two-stent technique you really master, preferably a technique which gives you the ability to come back to one stent if you have good result on side branch, what we call a M technique on the MATS classification. I thank you for your attention.
Thank you very much, Bernard, for this very nice presentation. I think we have learned a long time ago from Patrick the bump of events when you have a systematic angiographic follow-up, and it may impact the outcome of a randomized study. So, Patrick, do you want to comment about that?
No, not especially. It's very clear that it's a well-known phenomenon which is very old. So you have to develop a technique where you have an outcome which is not influenced by that. You know, this morning when I was looking at some of the slides of all these trials, what is critical is that it was Azim presenting. Azim is an hybrid. He do TAVR and he do coronary artery. Now, in the TAVR, we are all going to 10 years follow-up. It's becoming a must from the regulatory point of view. In the bifurcation, we are not there. And I think that I learned recently in the syntax that everything could be fine with 2 stent versus 1 stent at 5 years. And suddenly came the divergence. So that makes me a little bit nervous about the long-term follow-up. We talk about medium-term, long-term, and very long-term. And we don't have too many data about the very long-term. When you think even with ultra-thin stent, 3 struts compact, that makes already 180 micron of metal in a very special place with the stress on the wall. I'm pretty sure that if you do very late OCT, you can find funny things there. I mean, I would be surprised that Mother Nature accept 3 strut compact and intercross, and so that's my gut feeling.
So the big question also is the lesion length in this study, which here, if I remember well, is about 17 millimeters. So I wonder if it's possible to treat a large branch, which is 17 millimeter in length of lesion, without a stent. It's quite impossible. So yeah, you had a comment?
Yeah, on the decay crush versus culotte versus provisional, especially on the decay crush, I never understand like the mechanism really of action. You know, what is driving the data? Because what is it that makes decay crush having better result in the end? What is the mechanism that drives that? Is it better coverage? Is it, you know, the twice kissing, or what is driving that?
I think the conclusion is done by Bernard that if you do a good decalcrush and a poor provisional, the decalcrush will win. So this is, I think, the main lesson that we had from decalcrush 5 and definition 2. Yves?
Just about the problem of bump and relationship with reintervention. As Patrick and Thierry explained why doing the coronary angiography before generates this bump. And this is because the reintervention rate was not systematically influenced by a physiological assessment. Remember the nice pictures that Bonkonku showed us in the past with very tight or even critical lesion at the ostium of the left main with a FFR 0.95. So if you don't go for reintervention based only on physiological assessment, you are creating this.
Yeah, Patrick. And then Robert.
You will see very soon in circulation, we pull 3 studies that we have done, so 4,600 patients, and we did the classical clinical adjudication by the CRO versus the QFR in all these lesions. All these lesions have been retreated, and the discordance is phenomenal, okay? So an adjudication and a reintervention based on QFR versus clinical adjudication by a committee, that's how I learned less this year about what it means, yeah?
Robert?
Yeah, I want to follow up on the discussion on the angiography-driven TLRs, etc. You know, we also have to realize that these studies cannot be blinded. We have seen that even if you blind the FFR, you will find strange results, that we don't have to treat patients even with positive FFR. They are somehow optical medical treatment is very good. So now we have a study which is driven by an angiography follow-up. And if you don't like the results, meaning sometimes you didn't put a stent in the provisional side branch arm, in the end you are going to treat it. So be careful with this unblinded studies where we have not make sure these conclusions.
A comment from Geuns? Oh, sorry. You have your microphone, so let's start.
Okay, thank you. It was about the mechanism that Nicolas Foin asked. I think the key point of DK crash is that the first kissing is through the proximal cell. And the mechanism, I think, is when we crush the stent, we are thinking of the bifurcation in distal proximal part, we are detaching the stent at the side branch at the distal part. In the first kissing, the effect that is having, you are crossing by the proximal part, you reattach again the crushed stent at the side branch, you reattach again the distal part. So I think this is the key mechanism. It's not just adding another kissing balloon at the beginning to facilitate the access. It's just that you reattach the distal part of the side branch that you have detached when you crush the stent. I think this is the key part of the mechanism that should be emphasized.
We're actually trying to discuss the different results of the different trials with different techniques. But again, I think if we respect the laws of logic, we have one trial which shows superiority in one setting, the DK cross trial, and we have another showing that there's no penalty of choosing one stent against one technique against each other. And then we ended up discussing that DK cross is the preferred treatment. And there's no logic in that. Of course, it's a personal perception for a lot of people because they like the procedure and they are capable of doing it, so it works. But if we need to be totally strict, we have to underline that DK cross has excellent results, giving the caveats in the evaluation after 1 year. But we have a lot of metal. So this is a choice between a lot of metal up front and reducing the metal in another procedure, and we can't do both. So we have to choose. But the rule of logic is that we can't interfere anything about which thing is superior from the trials we have. But we have actually a good reason for doing what we're doing, whatever we're doing one against the other, until we have long-term follow-up.
Vladimir, you wanted to comment?
The question arose, what is it about the DK crush? What's the logic behind the DK crush? So it is it's not the kiss, it's really the recrossing, and it's the complete coverage of the ostium of the side branch that you achieve with the technique. The reason you kiss is because when you inflate that balloon inside the side branch, you cause winging, and this was shown by Xiaoling, and it was actually demonstrated by myself as well in a prior iteration of the technique. So the reason for the kiss is to actually reduce or eliminate the winging that you get into the main vessel by opening the struts of the side branch. So the key is that you get the absolutely the most complete coverage of the ostium if you do, as was mentioned, the proximal recrossing, so that if you do distal recrossing, you can actually go abluminal again and actually deflect the struts off the ostium. So the proximal recrossing is the key. You know, this is a topic I was given. It's not that I believe that all complex bifurcation should be treated by DK crush. It is the best technique when you need to choose a two-stent technique. Not all of them need a two-stent technique. Do all branches that have a 20 millimeter lesion length need a stent in the side branch? Well, if it's severe, if it's tight, if it's complex, if it's 60% and it remains open, maybe it doesn't, but probably most of them do. So I think that's the key about the DK crush, is that it gives you the absolutely best coverage. The concerns about 3 stents, I've done a number of OCTs at as far as year after the DK crush. It's well endothelialized. There's no chance of really of late or later, if you wish, problems with this, because it's well endothelialized. With current thin strut stents, it's not an issue.
Vladimir, how can we explain that DK crush can be better than inverted T or inverted culotte or inverted tap?
You know,
you have 3 layers of struts with DK crush instead of.
So my problem with the tap is that especially in acute angle bifurcations, you may have quite a bit of material in the main vessel, quite a bit of stent material in the main vessel. That's my concern about the tap. I actually have done some reverse crushes that look pretty good, and the tap is good when you have a fairly T-like bifurcation. I'm not sure how good it is in large vessels when you have a large side branch and you have a narrow angle of how much strut you actually have in the main vessel protruding from the side branch. So that's kind of I think it's also about technique. Yes, probably with the best culotte, when you do a pot at each step and you do all the steps properly, that's probably going to end up with very good results as well. But you know, perhaps in the DK Crush 3 trial, obviously the bias is towards DK Crush. So I think that's what we have to ensure. And that's why we're doing our trial, to see that we can do this in other populations, that other operators, investigators can do this as well.
Okay, so we have a last comment in the room, and then Adrian, you want to talk?
I would like to underline a technical advantage in DK Crush in severe calcified coronary lesions. If you perform aggressive lesion preparation in both main and side branch and you have dissection, so if you do DK Crush, you have the advantage that you have always either stent or wire in each branch during all the procedure. So if you, for example, dissect with pre-dilatation both main and side branch and you do your culotte, you may have difficulty to recross to the dissected other branch or the top or whatever. If you have comment in that point.
Okay, so I think we will have a debate for 1 hour. Right?
Right, so let's not do that.
You have a very complex, very calcified left main bifurcation. A lot of calcium in left main, a lot of calcium a lot of calcium in the LAD. You do a dissection in the circumflex, you stand towards the circumflex. You have removed the material, so you stand towards the circumflex. What's the problem? And then you do a T-stenting, putting a stent in the ostium of the lady.
Okay, so we'll discuss.
So I think the beauty of the DK crush is that a difficult side branch, you have secured it. It's done.
But the same with inverted, Vladimir. Exactly the same with inverted approach. So, okay, let's go back to Adrian and vote after his comment.
So the voting system does work, so please do vote.
Okay.
The vote online was the same as the vote in the room last time, so that's great. And my comment perhaps is that this was a carefully worded question. This was not any bifurcations. This was definition 2 bifurcations. So long disease in the side branch. And I think most of us would probably feel that 2 stents are going to be required in that type of lesion. And we've got to look at the data. And my comment perhaps would be that perhaps DK's weakness is its strength. You know, it is a pre-prescribed routine procedure that you do all the steps. And therefore, if you know the steps and you do the steps, then you get what, like cooking, then the recipe works. And of course, the provisional perhaps is always going to be likely to be more operator dependent because you're making the recipe up a little bit as you go along and you have to think and you have to decide. And perhaps as a consequence, less experienced operators may struggle with that approach. And that's perhaps what we saw in China. So let's have Thierry, perhaps you could supervise the vote in the room, but we're voting online at the moment.
Yeah, we are doing that.
Do you want to take a hand vote as well, just out of interest? Certainly online, people are saying that you should always do what you're comfortable with. I think very few people are going to argue with that. And I think the other thing that's interesting, and we've been talking about at EBC, is the virtual learning in order to improve our skills with these complex techniques. And there's certainly a strong argument with that.
I can just make one more comment. DK crush does not have to be a predetermined procedure. So DK crush can be, the choice of DK crush can be done after lesion preparation. So you have complex anatomy, calcified, long lesion. You've decided that you were maybe going to treat this provisionally or with other techniques, but after preparation, it still looks ugly. At that point, you decide that it needs to be a 2-stent procedure, even less complex. You're not getting a good result from preparation. At that point, you provisionally make the decision to go with a DK crush.
So I believe online we've got a 3-to-1 vote against you, Vlad. And Bernard is...
That's fine. That's fine. This is Europe. This is Europe. This is what I would expect. If 1 in 3 believe otherwise, I've won.
Well done.
I was afraid, Vlad, because I was afraid that you were really convincing everybody. So it's not the case. Okay, so we'll move to the next question, which is stent left main procedures are unsuitable for attenuated DAPT regimen, and DAPT should be continued lifelong. Pro Marco Zimarino and con David Capodanno.
Dear Chairman, thank you very much for the invitation to the EBC Congress 2021. And I'm sincerely concerned for defending my presentation on the issue 2 stent left main procedures are unsuitable for attenuated double antiplatelet therapy regimens, and DAPT should be continued lifelong. That is my point. Concern why? Because we are witnessing a historical context where there is a mushrooming of publications on all the drawbacks on double antiplatelet therapy after PCI, mostly in patients with high bleeding risk. And this is strongly supported by the recent publication of the sub-analysis of the Twilight Complex investigator led by George Dangas, where you can see that there is no reduction in ischemic events at the cost of a significant decrease in bleeding events when ticagrelor is maintained after withdrawal of aspirin early after complex PCI. Such findings have been recently replicated by the sub-analysis of the Smart Choice trial, always among complex patients where bifurcation is a big part, and results are similar. On the other side, I have to face the public prosecutor who has written a landmark manuscripts on physiology and pathological distribution of the plaque in left main coronary artery disease, as well as elegantly depicted the difficult balancing between the technical complexity of approaching left main and the extension of the territory at jeopardy when approaching the left side branch. In this manuscript, you can find also the technical peculiarities of this approach that have not to be disregarded, as the careful planning is strictly correlated to long-term outcome, as here you can see in a couple of recent publications that double stenting, when not planned, bears an increase of 1.8 hazard ratio in hard endpoints events. And this risk can be attenuated by careful imaging that allows adequate stenting positioning, vessel wall deployment, symmetry of the struts, and in some cases, as in this one, when monitoring, it can also depict uncovered parts of this relevant part, as here you can see the ostium of the left circumflex not covered by a T-stenting procedure. Therefore, there are no currently available manuscripts focusing on that duration, but they are mostly derived from large trials in which there are sub-analyses available on complex patients. The only one is this one, published from a subgroup of the Geuns trial, where DAPT interruption does not have any drawback in patients with single stenting, but has an increase, a threefold increase of hard endpoints when the procedure is not supported by careful imaging. Therefore, we wrote together with my public prosecutor a white paper on the antithrombotic therapy after percutaneous coronary intervention in bifurcating lesions, where there are 4 issues that we focus on: clinical presentation, bleeding risk of the patient, stenting strategy, and intravascular imaging. These have been the main image, the central image. We can disregard the single stenting strategy. We can focus only in double stenting and bailout stenting. And we suggested a prolonged duration on the antiplatelet therapy after such procedures. Now, when patients have high risk and when there is imaging, careful imaging, we reduce this suggested duration. And after the publication of the Twilight Complex as the smart choice, I'm also willing to negotiate this point, shortening further to 3 months in very selected cases when the patient is at high bleeding risk and IVUS has been performed to optimize the strategy, and to reduce to 6 months when the patient is at low risk and the IVUS has been performed. But I'm not available, I'm sorry, to go further than this point. Thank you very much for your attention.
Thank you, Mr. Chairman, and thank you for the invitation to EBC 2021. In this controversy, the title of my talk is Two-Stent Left Main Procedures are Unsuitable for Attenuated DAPT Regimes, and DAPT should be continued lifelong. I don't know if lifelong is the correct word here, but of course I will refer to standard DAPT 12 months in particular. So let's start with some randomized data, because we have randomized data in this domain. The ideal left main trial was presented a couple of years ago at TCT and will be published in Your Intervention soon. This is a study of 818 patients with an indication for left main coronary artery disease revascularization by PCI. And these patients were randomized to 4 months of DAPT versus 12 months of DAPT. It's also worth mentioning that in this study, the patients receive a different stent device in the 2 groups, which may add some level of confounding. However, both stents were eluting everolimus. The primary endpoint was all-cause death, MI, or ischemia-driven target vessel revascularization at 2 years, and the study was powered for non-inferiority with quite a generous non-inferiority margin, 7.5%. So the rates of the primary endpoint at 2 years were 14.6% with the 4-month DAPT group and 11.4% for the 12-month DAPT group. The non-inferiority was met because the one-sided upper limit of the 95% confidence interval was 7.18, so just below the 7.5% that was pre-specified as a non-inferiority margin. The P for non-inferiority was at 0.04 and the P for superiority was at 0.17. However, we should be cautious with these results as discussed by the authors in the paper, because not just because of the non-inferiority margin, but also because, as you can see, the number of events in the control group was much lower than expected. They expected 20%. So in this context, of course, we are not sure whether the non-inferiority margin would be reached with a different and narrower window of non-inferiority. By the way, the conclusions are also a bit undermined by what we see in the secondary outcome of BARC 3 or 5 type bleeding, where we see that there is some level of play of chance, probably due to the low number. In fact, there was more bleeding with a 4-month DAPT regimen, 2.7% versus 0.5% in patients on a 12-month DAPT, which is exactly the opposite of what you would expect. When we look at component endpoints, there are also some worrisome signals. No difference in all-cause mortality, but numerically more device-oriented endpoint rates, 11.9% versus 9.6%. There was a double rate of spontaneous myocardial infarction, 4% versus 1.8%. And if you see a definite or probable stent thrombosis, you see also a doubling of events, 2.7% versus 1.3%. Finally, the authors also presented the results of a sub-analysis by number of stents implanted. Multiple stents were implanted in 20% of the patients. So this is a similar population to the one that we are discussing today in this controversy. And you see, again, a doubling of events in patients who received short DAPT, 12.9% versus 6.8%. So, of course, this was not a powered outcome, but make you reflect that perhaps shortening DAPT is not appropriate in these specific circumstances. When we look at the ESC guidelines for chronic coronary syndromes, we see that the indication for dual antiplatelet therapy duration is 6 months following coronary stenting, irrespective of the stent type, unless a shorter duration, meaning a duration of DAPT of 1 to 3 months, is indicated to risk or the occurrence of life-threatening bleeding. And this is class 1 level of evidence A. However, we also know from the 2017 ESC focus update on DAPT in coronary artery disease that there are some specific scenarios of complexity where prolongation of DAPT may be indicated. And that's the case, for example, for bifurcation with 2 stents implanted. For these patients, we have a specific recommendation, class 2B level of evidence B, that prolonged DAPT duration may be considered in patients who underwent complex PCI. Finally, I think that what we have to keep in mind in this controversy is that the duration of DAPT may be personalized. And essentially, this is based on the clinical presentation, stable CAD or acute coronary syndrome, the number of stents that are implanted, and within the two-stent group, of course, it may make a difference whether the two-stent strategy was planned or it was a bailout. And of course, we have also to factor the risk of bleeding and the presence of imaging performed, IVUS or OCT. So you see that in this consensus document from the EBC, first author Marco Zimarino, there are different durations of dual antiplatelet therapy depending on the presence of a high risk of bleeding or the presence of imaging. So we go from 3 months to 12 months depending on how much these factors are combined. And of course, we didn't mention so far the other important scenario, acute coronary syndrome. Here, the dual antiplatelet therapy is important beyond the left main because, of course, of the protection on the other vessels. And you see that here the minimum is 6 months in situation of high bleeding risk and imaging performed. But then we go to 12 months or even more than 12 months for patients that have, for example, low bleeding risk and no imaging performed. So this was my last slide, and I would like to thank you for your attention.
Adrian, do you have any comment?
I think there was quite a lot of consensus expressed by the two speakers, actually, at the end of the day. But
I agree.
which is nice to see. But one of the things that strikes me is this issue around imaging, and it keeps coming back, doesn't it? And I think one of the nice things in Marco's document is putting that, reflecting the confidence of imaging in your prescription when the patient leaves the hospital. And I think that's, I've not seen that before in any of the guidelines, and I think that's very, very interesting. Perhaps we could ask Sonia, imaging in your left main cases, what sort of percentage do you do, and does it influence how you prescribe for the patient on discharge?
Oh, it's very difficult in our country because of very low funds, and imaging is quite not so possible in our cath labs. And we have to perform just procedures very often without available imaging in everyday practice. And it's something like in peculiar cases, but we have to do procedures and in acute coronary syndrome and also in chronic coronary syndrome. And we have to rely on some clinical manifestations and on some guidelines. I think, in my opinion, that we have to look at the patient clinical occasion and to look at the ARC-HBR proposed algorithm for bleeding risk, because all of us know that ischemic risk is the highest in first 4 weeks after acute event, but bleeding risk remains highest than ischemic risk. It's a first point. Second point, that we have to look at the other risk factors because we have no possibility to perform imaging in every patient. And we have to look at the other aspects of some patient and some clinical presentations. I think that in the last published studies and articles, bleeding risk is highlighted and more emphasized. And we have to look at the procedure combinations or two-stent procedures, and then to decide where to continue, when to continue, or to stop DAPT. And another question and another point is worsening of glomerular filtration rate and atrial fibrillation and necessity of oral anticoagulation therapy. And of course, sometimes relying on COMPASS study, sometimes to combine with oral anticoagulation and ticagrelor in a lower dose, or it's my opinion according to last data.
It's certainly a problem that many high-risk patients are high bleeding risk, high ischemic risk,
yes, and
atrial fibrillation,
high-risk
high
patients.
everything.
High-risk patients often died, unfortunately.
So Thierry, the vote is open, so encourage people to vote, but what's the view in the room about this question? 2 stent left main procedures are unsuitable for attenuated DAPT. What are people saying in the room?
Okay, so we can vote now.
So the vote is suggesting, so 2 to 1, that left main should be a special case and should not be suitable for attenuated DAPT. Is that the feeling in the room, Thierry? 72 to 28 at the moment online.
But Adrian, you're talking about attenuated DAPT. I think in general EBC says that if you have 2 stents, you should not do shorter than 12 months. So is there a difference then?
Well, that's the point of the discussion, isn't it? I mean, what I'm saying is an awful lot of people are moving towards these attenuated regimes of 3 months or whatever. I think many of our left main patients are at high risk of bleeding. And the point of the question was really to ask whether if you have a 2 stents in your left main, are you special? And I think the answer from the audience is yes, you are special, and you need to probably not be looking for a very short dual antiplatelet regime.
Fully agreed, but I think we still keep the statement that all 2 bifurcation stenting lesions, even if it's non-left main, should be on 12 months.
Well, that may well be the case. I agree. We are very late, so perhaps we should move on, Thierry. What do you think?
Yeah, I think the question is not very clear, unfortunately.
I totally agree. Left main has a lower thrombogenicity than the others, but a higher jeopardy. So I would say every double stenting.
Thanks, Marco.
Okay, so Gerald, who is a CTO guy, but also a bifurcation guy, will have a helicopter view about this discussion, I think.
Yeah, what I missed as an argument in this discussion between a bifurcation of the LAD and the diagonal in the left main of the circ is the diameter. And we've learned from IVUS that the diameter, the large diameter, is a positive factor in favor of freedom of stent thrombosis, freedom of stent restenosis. So I would rather argument that the left main and the circumflex, if you want to reduce DAPT therapy, are more likely to have no problem than a regular bifurcation at the distal right or in the mid-circ, because the diameter prevents thrombosis.
Yeah, I fully agree with you, but it depends on what you have done in this large diameter. So if you put 3 layers of stent, you don't do pot, you don't do kiss, then the risk of stent thrombosis can be very high. But if you have done a good job and you're happy with the final result, and maybe to introduce coronary imaging or good feeling during the procedure, then I think the risk is very, very low. I agree. Adrian, you think you have the same thinking?
I think that was beautifully summarized, Thierry.
Okay. Yes, Geuns.
Well, there is another approach that we haven't discussed. But every day you are on anticoagulant therapy and you don't bleed, your risk of bleeding the next day is less. Every day you are not on anticoagulant therapy, your risk of having a stent thrombosis the next day is higher if we look into the epidemiology.
Yeah.
So that is actually, we have 2 endpoints and we're discussing one strategy, and that's always difficult.
Yeah, I fully agree. And in my center, we are thinking that it's better to have a planned stop instead of abrupt stop, because the patient had a problem and he may need surgery, and this is a worse situation. So I fully agree that it's very, very important to have a planned stop à la carte according to the patient, according to what you have done, according to the bleeding risk, etc., etc. Okay, so it's time to conclude. I think